Chairman, dear colleagues, first of all, I would like to thank you, the organizers, especially Professor Ma, for opportunity to be here and present some data regarding remote magnetic navigation. So I have nothing to disclose, but me personally and my team, we have an experience more than 1,200 plus robotic procedures with different arrhythmias. So, and in my talk, I will focus briefly on the main direction where we use robotics. So, robotics for AF ablation procedure, for atrial tachycardia and congenital heart disease, for VT ablation, maybe robotics for other procedures, and what are the nowadays the way for long distance robotic procedure. And of course, we have some expectation about robotics. First of all, we expect that this procedure will have the same or maybe high efficacy, the highest safety with the standard technology, of course, the least fluoroscopy time, and it can be more feasible in complex anatomy and in large heart chambers. And if actually we are looking to the literature, to the PubMed search, and the using of remote magnetic navigation story started in 2004, and till now there are 400 and I would say 50 plus publications already. So first of all, I would share with you some largest experience from actually Professor Q Jin from Shanghai, from China. 3 years ago, he published one of the biggest experience of more than 1,000 procedures with robotics, and you can see here that the vast majority of the patients were with atrial fibrillation. And the total complication rate in this cohort of patients was 0.5%, 99% of the acute successful PVI, 19% of acute success in VT ablation, and the mean X-ray time was about 5.3 minutes. Of course, it's not fluorless, but it's still, I think, acceptable. The learning curve to the procedure is around 30 procedure and the duration of 126 minutes. So, robotics for AF ablation. A lot of publication on these topics I want to summarize. And Dr. Kyujin also published this systemic review meta-analysis data. And if you look into the AF recurrence, 13 studies, 1,800 patients, no difference in efficacy. If you look into the complication rate, perioperative complication rate, robotic reduce the complication rate by 56% compare with the manual technology. The same story with the fluoroscopy time, and using robotic decrease by 9.7 minutes fluoroscopy time. But the procedure time with manual technology is shorter, and the ablation time is also shorter with the manual technology. There are a couple of publications which are not in line with this meta-analysis. Actually, the first direct comparison, even with the retrospective design, but it was done using the propensity score matching analysis, including 574 patients, you can see here, and the results show similar efficacy, no difference in safety profile, least fluoroscopy time with the robotic and longer procedure duration with robotic. But recently presented and published prospective ongoing registry comparing balloon technology, comparing the contact force manual technology and the robotic technology, showed superiority of the remote magnetic navigation compared with this two manual approaches. But once again, it's not randomized, it's ongoing registry, prospective registry, and I would say that I think the experienced users of robotic navigation participating in this registry. So how the procedure looks like for AF ablation, you can see the standard circumferential pulmonary vein isolation. In our clinic, we use the following settings as a 55 watts on anterior wall and 50 watts on posterior wall, and we use ablation history parameters reaching 250 and 400. It means how long the catheter is staying in particular point with constant power, and application duration is around 8 or 10 seconds. We also done the propensity score matching analysis, direct retrospective comparison, including 446 patients, and there are no difference in efficacy in paroxysmal atrial fibrillation, and we received the superiority of remote magnetic navigation in non-paroxysmal atrial fibrillation. My thoughts that in this patient, all this cohort of the patient had enlarged left atrial more than 4.5 centimeters, and due to flexibility of the catheter is easy to manipulate and reach true isolation and the best and the better contact than with manual. How this procedure works in complex anatomy. You can see here the case of the 50-year-old male with symptomatic drug refractory paroxysmal AF and left-sided superior vena cava. And also this patient has the atrial septum diverticulum or split atrial septum and no possibility for transseptal puncture. You can see in the right side of the slide the CT scan of this patient, and on this video you can see how we use a retrograde approach with the robotics. So you can see the reconstruction of the right and left pulmonary veins, and on the bottom of the slide you can see the fluoro position of the RMN catheter in the left superior and right superior pulmonary vein. So of course, this is not, let's say, a regular approach, but sometimes in very difficult anatomy, you can do the pulmonary vein isolation using retrograde approach through the aorta. So in summary of this topic, so far what we have: efficacy, similar data, safety, remote magnetic navigation based on several publications seems a bit better. Fluoroscopy time less in remote magnetic navigation group, but longer procedure duration and ablation time. And once again, no direct randomized comparison of prospective studies were performed so far. So the next group of the patients is atrial tachycardia in patients with congenital heart disease. You know, there is a classification of the congenital heart disease based on complexity as a simple, moderate, and severe, and the atrial tachycardia and atrial fibrillation in this group of patients is quite high. In general population, the prevalence of atrial tachycardia in congenital heart disease is around 15%, and it's increased during lifetime up to 57%. And of course, this presence of atrial tachycardia increase the hazard ratio of adverse event by 2.45 times, mortality 1.5 times, and stroke and heart failure of 2.2 times. So, of course, in the guidelines, there are some statements that ablation strategy can be performed in this category of patient when the drugs medical therapy is not effective. So this is a class 1 recommendation, and also some statements that remote magnetic navigation might be the reasonable technology for this category of patients in complex anatomy. And the biggest experience, once again, non-direct comparison, just division of 3 subgroup, was published almost 10 years ago with Dr. Sabina Ernst from London. And you can see here it was included 116 patients, and they were divided into 3 groups. In one, it was performed the manual procedure. The group 2 included robotic procedure, and the group 3 included robotic procedure with difficult access. And it was a variety of congenital heart disease type, supraventricular arrhythmia types. So in summary, it was no advantages of the approach, but I want to underline that in this series of patients, less than 50% had incisional atrial tachycardia. So so in this analysis was include patients with WPW, NVNRT, focal atrial tachycardia, and so on and so on. And actually, last year it was published the rationale and design of robotic registry, including pediatric patients and also adult patients with congenital heart disease. This is ongoing registry, which will include retrospective analysis of 200 patients and prospective analysis of 400 patients. Once again, the problem of late recurrence is in this cohort still exists. So also in our clinic, we've done a small study using propensity score matching. We compare the 39 patients with atrial tachycardia and repaired congenital heart disease and match it with a patient who were operated with using robotic. You can see also the variety of the congenital heart disease, and we matched these patients based on complexity of the congenital heart disease, and around 50% patients in both groups had moderate or severe congenital heart disease, and we received advantages of the robotic technology over manual and 36 months follow-up. No difference in complication rate and serious adverse events, including death, stroke, and MI, and others during the follow-up. And also we received less fluoroscopy time in this group of patients. But once again, small number of patients, retrospective design despite of direct comparison. This is also another case with a 9-year-old boy and weight 20 kilos. You can see very complex congenital heart disease with single ventricle atrioventricular channel, ASD, VSD, and this boy had 5 open heart surgery procedure, and also he had atresia of common iliac vein and right femoral artery thrombosis, and he had a symptomatic atrial tachycardia. So the only one way was to use retrograde approach through the left femoral artery. By the way, the diameter was 4 millimeters, and actually the patient planned to be performed the Fontaine procedure, like a last stage of the correction of this disease, but the surgeon due to atrial tachycardia, the surgery was postponed. And you can see actually the CT scan of this patient, and in this white line you can see the way how we should reach the target area in the right atrium. And also you can see the position position of the Arrhythmias catheter, which do 3 curves to reach the target spot in the right atrium. And the end of the story, the tachycardia was stopped, and now we follow up these patients more than 2 years. He fortunately successfully received the Fontaine procedure and feel now much better. So in summary, the same story. So efficacy, I would say similar or maybe higher than manual approach. Safety similar, fluoroscopy time less with robotic technology, also longer, a little bit equal procedure duration. Of course, in the complex anatomy, this technology is preferable, and no randomized study between the robotic and manual technology performed so far. One slide for VT ablation and for ventricular arrhythmias. This is a meta-analysis published 2 years ago. If we are looking to the VT recurrence based on certain studies, 80,000 patients, you can see no difference in long-term AF recurrence, but with RMN, the beta acute success rate, especially non-structural heart disease patient, and no difference in follow-up. But the total complication rate low using robotics, so decreasing by 66% risk reduction, and also fluoroscopy time less using the robotic. I think this is important for this category of patients. In summary, the same story, efficacy is similar, safety seems better with robotic technology, less fluoroscopy time, equal procedure duration, and of course, epicardial ablation with robotic technology is feasible. And no randomized study were performed. Some other applications for the robotic procedure. This is actually a case from our lab. We perform the pulmonary artery denervation in patient with pulmonary hypertension. Of course, in frame of clinical study, this is patients after with group 4 of pulmonary hypertension. After open heart surgery, he had resistant pulmonary hypertension, and without effect of standard medical therapy, and we performed the isolation of the pulmonary artery based on previously published anatomical work and based on the previously published data from Dr. Shaolian Chen from Nanjing, who was founder, let's say, of this technology. And now we conducted the randomized study in patient group 2 of pulmonary hypertension, so involving left heart diseases. So we took the patient with atrial fibrillation and pulmonary hypertension. You need to prove that this is post-capillary, so it should be a pulmonary wedge pressure more than 15 mercury. In one group, we perform standard PVI plus pulmonary hypertension, and another group, we perform just the standard PVI and sham procedure. Sham, in this case, easily to do, because for the PVI, you actually have the catheter inside the patient. So, and the last part of my talk, log distance till robotic procedure. Of course, sometimes it seems like a play, and actually Professor Carlo Papone performed this telerobotic procedure, I think maybe 10 or 15 years ago during AHS meeting. But we are from, let's say, from the Asia part of the world, we also decided to perform such procedures. And you can see here, 2 months ago, I was sitting in my lab, in my office in Novosibirsk, and control the robot in Shanghai in Rujin Hospital. So the distance was 4,000 kilometers. You can see in the short video. So with Dr. Kyujin, we had a patient with focal atrial tachycardia from the coronary sinus. So it was a very long story how we can prepare it, but by the way, the latency, the time latency of the moving of the catheter was only 100 milliseconds. It means nothing. So I was sitting in my office, and you can see I rotate the map, and actually it was no latency, and we successfully mapped this tachycardia, and Dr. Jin put the pedal and stopped the tachycardia. So it was a successful case that we performed 2 months ago. And 1 week ago from now, we tried to organize, like, let's say, long-term telerobotic marathon. And we do the procedure from the Hong Kong during APHRS meeting to Novosibirsk, and also between two centers in mainland China. And also Dr. Jin control the robot in the Shanghai laboratory in the distance of 1,200 kilometers. And this is my last short video. You can see, I will show you in a minute, this is our lab. This is the mouse you can see, and this is a moving of the map of the right outflow tract. You can see here that no one touched the mouse, and I rotate the vector and also change the direction of the catheter, and I ask my colleagues who is sitting just to put the pedal. Of course, he will decide if the catheter is moving, he stopped ablation, but once again, the latency was also around 100 milliseconds, so it means nothing, and it means that this kind of approach can be realized, especially in big territory. In China, by the way, there are 8 robots with different centers, so we can use it and we can ablate patient with a complex anatomy. And thank you very much for your attention.
Thank you very much. We have some time left for questions and answers, not very much.